Hi, everybody. Thank you so much for coming to this CoLab Presents webinar. We are really excited to have Ginger Sullivan here, and she's going to be speaking about gender analysis in prescribed safer supply, which I think really fits in with the vibe of this project. We have monitoring and evaluation as the key tenets of the CoLab project, and this analysis is taking that monitoring and evaluation to the next level. So we're excited to see this presentation from Ginger.
Great. So good morning, everyone. Thank you, Brittany. My name is Ginger Sullivan. I go by she, her pronouns. I'm a nurse and a PhD candidate in the School of Nursing at the University of Victoria. I'm grateful to be joining you here today, this morning, to share a little piece of my doctoral work. As Brittany has mentioned, my work focuses on a gendered analysis of prescribed safer supply. Just before we start, I want to mention that I plan to talk for about 20 minutes and then hopefully leave time for some interesting discussion and questions. Brittany, I'm not very good at monitoring the chat while I'm talking. So if there's things that come up, feel free to interject or flag it to me, or we can talk about it at the end.
That sounds great.
I just want to start with an acknowledgement of the lands. I'm joining you from Treaty 6 territory, Amiskwaciwa-Saken, Beaver Hills House, colonially known as Edmonton. And just to personalize this for me, I've lived and worked most of my life on Treaty 6 territory. I actually grew up on the land. I grew up on a farm, which is the traditional territory specifically of the Blackfoot and Cree, and then later the Métis people. And I've actually moved back and I continue to live on the land. So just acknowledging that my family and myself are really uninvited guests, and it's a privilege to be able to be here and live here. I also want to acknowledge that the research that I'm going to be talking about today, the activities that were completed as part of the research, took place on the traditional, unceded, and continually occupied lands of over 200 First Nations in what's colonially known as British Columbia. It's really important for me and our team to acknowledge that none of this work would be possible without the folks that shared their time and their experience in participating in our research. That's what made the work possible, and as well acknowledging the people with lived and living experience that continue to advocate and lead these ethical responses and equitable responses to the ongoing overdose emergency across the province and also across the country. I want to also acknowledge the broader team that I worked with, so the folks that are part of CoLab, the folks that are part of the broader study, which my PhD research is a part of, my supervisor, Bernie Pauli, another mentor and part of my supervisory team, Karen Urbanowski. And I also just want to acknowledge Marion Selfridge collected the bulk of the data that I drew on from my PhD work. There's lots of other folks, some I even see here today, that are part of the team, but also the peer research associates that worked with us to make the research possible and inform us and lead us along the way. My PhD work was funded and supported by a CHR fellowship, and the broader research, the mixed methods evaluation that my research is a part of, was also funded by CHR. Just what I quickly hope to share, I want to start off with a few notes on terminology. Language is really important and how I used it in my work. Talk about how I ended up pursuing this topic and being in this research, and then talk a little bit more about the gendered analysis and share some findings and some key recommendations. In terms of terminology, I think it's important we acknowledge the use of language. In my work, when I use the word woman, I'm referring to anyone who identifies with this gender. Similarly, when I use the term men or man, I'm referring to anyone who identifies with this gender. Throughout my work, you'll notice that I use the terms gender diverse person or gender diverse people And that's really to signify anyone whose gender identity falls outside of the socially constructed binary, and anyone who identifies as non-binary or transgender. As I go through the work, I talk about the gendered analysis of prescribed safer supply. So I specifically looked at an analysis of the risk mitigation guidance that really provided the clinical guidance for the initial, some people use the term pandemic prescribing. That was really the guidance that supported the prescribing of tablet opioids, stimulants, and benzodiazepines in the early stages of the dual public health emergency. So I know you're probably all familiar with the term risk mitigation, but just to make sure that's clear. So I apologize. I know this is a little bit of a lengthy introduction, but I think it's really important to contextualize. As I mentioned, I am a nurse. I identify as an uninvited white settler. And how did I come to this work? I know some of you know me in the room, but for those of you who don't, I have worked as a nurse in substance use and harm reduction for over a decade. And I've been fortunate to practice in various settings in British Columbia, Alberta, and also internationally, working in across the continuum in substance use treatment, withdrawal management, and on outreach harm reduction teams. I also identify as a cisgender woman, and I am a mom, I'm a partner, and I am a daughter of a person who uses drugs. And so I think these identities have all come together, and my experiences have led to me doing this particular topic and this work, and coming to U of IC and working with Bernie and her team. So now getting more into the focus of today. This is part of my PhD work that focuses on gender analysis of prescribed safer supply. I won't be sharing all parts of my research, but I do focus on two key pieces. So I describe them as two separate studies, but they're related. So the first one is really an intersectionality-based policy analysis of looking at the policy directions and the clinical guidance that really informed risk mitigation prescribing. And I'll share my methods and my findings for that. And then also the second piece was a secondary data analysis of qualitative interviews of folks who self-identified as women or gender diverse that accessed or attempted to access RMG prescriptions in 2020 and 2021. To just give a little bit of background here and why the focus on gender. And as Brittany mentioned at the beginning, looking at equitable responses, gender, unfortunately, when we think about harm reduction responses, it's sometimes underfunded, underdescribed, underacknowledged. But we do know, and why this is problematic is that we know that women and gender diverse folks experience unique, both personal and structural barriers when attempting to access substance use and harm reduction services. Less is actually known about gender diverse folks, but we do know that they also experience gender discrimination. So it's assumed that similar gaps exist. In terms of what we know in the existing evidence, the majority of research that focuses on women's substance use focuses on proximate or individual level barriers. So things like past histories of trauma, partner violence, which of course is critical. But our research and more recent research is really looking at how those individual barriers intersect with broad structural barriers. So the gender discrimination that's present in our policies, in our institutions, and in our practices. So this is really the foundation that led me to wanting to focus on a gendered analysis of prescribed safer supply. When I entered the PhD program, I had a little bit of a different focus, but for any of you folks who have done a PhD or even research in general, it shifted and changed. So eventually led to this gendered analysis because that fit with my interest, but more importantly, about what was going on in the province at the time. So this was early 2020. So the study approach, the first study was an intersectionality-based policy analysis of clinical guidance documents, so IBPA. So essentially what this is really, it's a framework that can be used. It was developed by Hank Kavinsky, who's actually a scholar at SFU. And it's just a framework that can be used to analyze any documents that relate to policy or practice, health policy or practice. So that's what we did for the first study, and our research question, and I'll talk a little bit more about what we actually did and how we did that. But our research question was, do the existing clinical guidance and policy direction on prescribed safer supply address the unique needs of women and gender diverse persons in BC? And then our second study, which fit well after looking at the policies and the practice, then I was fortunate to be able to draw on the qualitative data of interviews with women and gender diverse people who actually accessed or attempted to access and prescribed safer supply. So our question for that was, what were women's and gender diverse persons' experience accessing or attempting to access prescribed safer supply during the dual public health emergency? In terms of our sample, so when I talk about this policy analysis, the data was really the documents. So we drew on 3 guiding documents that I'm sure you're all familiar with. The first rendition of the risk mitigation guidance, and then the update that was released to the guidance. And then we also included the prescribed safer supply policy direction document. For our second study, we drew on qualitative data, and we had 21 folks who self-identified as women or gender diverse who accessed or tried to access a prescription. So in terms of our first project, I already mentioned that this IBPA framework is really a policy analysis framework. It's quite flexible. And the focus is really to look at gender, to look at how policy and practice documents address gender or integrate concepts around gender, but also other intersecting identities and factors. And that's why we ended up landing on this framework in particular, because we know that gender intersects with multiple identities, with race, with class, with ability. And so we didn't want to just focus on gender in our analysis. And so what we did is essentially we used the framework, we pulled up the documents, and you start with, it's a 3 sort of part process where you just read and familiarize yourself with your data, which is the documents. And then using the framework, there's guiding questions all about equity that include gender, gender identity, pieces around race, and we developed a coding framework. And then once we had that, we used that framework to extract data from the documents. And so we did that, and what did we find? In general, we found that in all 3 of our documents, gender is mainly silent, unfortunately. Only the PSS document mentioned women, and it was mentioned 4 times, and gender was also mentioned 4 times. And again, it's not, when you do a gendered analysis, a document analysis, it's not just looking at the number of times, it's really looking at how is gender actually attended to in the documents. And in the risk mitigation, and I call them RMG1 and RMG2, Gender or related terms weren't included except only in the context of a highly biomedical focus, which was the gendered experience of pregnancy. So that was the only mention of gender at all, was the gendered experience of pregnancy. And then unfortunately, none of the documents mention any specific considerations to address known gendered barriers for women and gender diverse folks. And just to pull a few pieces here, I'm sure you're all quite familiar with the documents, but in the risk mitigation clinical guidance, so again, that's the clinical guidance that informed folks that could prescribe pharmaceutical alternatives. The only piece that came up again was around pregnancy, and the only representation of that was just extreme caution should be used and care should be provided in collaboration with patients' obstetricians. If available, a perinatal addiction specialist should be a thorough discussion of alternatives, risks, and benefits should be had with the patient, including potential risks to the fetus. So you see this, again, unfortunately, this focus on risk and caution. In the policy documents, in the policy directive, I should say, there was a section included on gender-based analysis, which we were happy to see. And also it was described in this intersectional framework as well. So acknowledging that gender does intersect with other factors that shape how services respond to people's needs in terms of access and barriers. And while this was included in the policy direction, no meaningful recommendations or elaboration was included. I know this is a very busy slide, and it's not meant to be super meaningful here, but I just, in case you're interested and want to look at this after, I want to share now the findings from our secondary data analysis. So our secondary data analysis, we used interview transcripts, and we specifically looked for how gender, both personal and structured experiences of gender, impacted people's ability to access RMG and the impacts of accessing RMG prescriptions. I just want to say here that out of the 21 participants in the sample, 13 participants self-identified as white, with a smaller number identifying as Indigenous, 2 people identified as non-binary. All participants reported use of criminalized drugs and varying degrees of socioeconomic marginalization, and that was determined by housing and other factors. And nearly half, 42.9% of participants, had 1 or more children under the age of 19. So what did we find? Overall, we found that while women and gender diverse folks identified both positive and negatives accessing RMG prescriptions, the intervention didn't disconnect them from the illicit supply. Our analysis found sort of 3 primary themes. One was a concern around safety and parental concerns. As one participant shared, this is her words, "I wanted to try and ask my doctor about RMG, but I'm a little chicken to do that. I don't want to. I hate seeing my doctor. I'm always scared that if I've been using because I have a daughter. I don't like telling them anything. One side of them says, you know, it's confidential, but there's a huge poster on the wall that says, I'm a mandated reporter. So I know many women and mothers that won't tell anybody anything, even to get counseling or help. They're scared out of their mind." This participant went on to share that as part of this program, RMG, I definitely do a lot more to get information to people. I would help women and men with kids be more comfortable coming in and talking to someone, because it's really scary for women. Another theme that arose was that participants described that how having access to RMG decreased criminalization. Several participants explained that after accessing RMG, they no longer had to trade or steal. And this is a quote from one of our participants, "I've actually managed to make it through the system. I'm not even on probation anymore or anything. And that's been the case for a year and a half now." That was from Safe Supply. So I'm super duper grateful for that. And I'm not committing petty crime. And also I'm not having to do sex trade work either. And then finally, but very importantly, a theme that arose was around increased autonomy. Several participants explained that having access to medications, even though in many cases it was not their drug of choice, not the correct dose or their preferred route, they explained that, again, their words, just having it offered a sense of control over their own use when there's such an unreliable illicit supply. Others describe using RMG medication to organize and determine their own goals around substance use. And as one participant shared, "I took half of it, RMG prescription, and I spent half of it on down and then half to buy food and snacks and stuff for the night. And when I came home carrying some snacks and stuff, it felt good. Like I get to put this little bit of food that I have in my fridge and in my cupboards, and it felt, well, empowering." Well, yeah, empowering. I felt like I had more control. So before I kind of share a few of the key pieces and recommendations, I just want to acknowledge the limitations of this work. The findings from both the policy analysis that I talked about, as well as the secondary analysis, they're specific to a particular context, which is during this dual public health emergency. I did do a secondary data analysis. So in the interviews, we didn't explicitly ask about gendered barriers or gender specific services. So this is something hopefully we can do and the team can do going forward in the broader safe supply evaluation. And then as I mentioned, only 2 folks in the sample identified as non-binary, and there was a limited perspective of gender diverse persons. To wrap up here, just some key messages and recommendations. Some I've already shared, but limited to gender and other intersecting identities in the policy and practice directives is what we found. And similarly, limited attention was paid to offering gender responsive, prescribed safer supply programs and services. And this isn't to say that if something is in, as I'm sure all of you know, if something is in policy, it doesn't mean, or in clinical guidelines, it doesn't mean that it's going to translate into our programs, into our practice. But if it's not there to begin with, it's very probably more unlikely that it won't show up in our programs and in our services. So that's unfortunate. While women and gender diverse people identified both positive and negatives, I said this, impacts in accessing RMG prescription, the intervention didn't disconnect them from the toxic illicit drug supply. What I think is valuable, a big takeaway from this work, is that participants did offer insight into potential improvements, including gender responsive models that focus on physical and psychological safety, formats that include women peers in the delivery model, and supports to address the socioeconomic structural barriers. And then finally, future programming and support should focus on women's and gender diverse persons' strengths and autonomy in navigating access to prescribed safer supply. So I just want to say too that while these are all of our recommendations, I do think that without the addressing some of the broader structural pieces, so the continued criminalization, and especially the regulation of pregnant and parenting women, even all of our best laid plans and models will likely not be effective. And also just acknowledging that gender does intersect with other locations. So these kind of recommendations should also be included with things such as universal childcare, access to minimum income, and some of the other pieces when women talk about supports to address some of those other structural barriers that they experience. So that's it. I look forward to discussing.
Yeah, sure. You kind of waste.
Awesome. Thank you so much for such a great presentation. That was so interesting to learn about. And I think like the fact that women are only sort of referred to related to pregnancies is like a really interesting thing to think about. I really appreciate this presentation. So I'm going to press stop on the recording so we can have a nice discussion with the folks that have attended this presentation. Thank you again, Ginger.